Sai sir, are we live now? We're just waiting for Sai sir's cue. Once he's done, we are
live now, doctor. Please start the session.
Dr. Balamurugan sir, over to you.
Good evening all, and I'd like to welcome you all for this 10th International Conference on Diabetes called Cupid COVID Update Program in Diabetes. It's in the 10th year. This year from national, we upgraded to international conference. We are starting with the International Diabetic Retinopathy Conclave. Our hospital is called COVID Diabetes Specialty Center and Hospital. We have been organizing this diabetes conference for the last 10 years to inculcate and propagate the knowledge on diabetes and related issues to all the healthcare persons throughout the country. And this time we are taking it to the international level, starting with an International Diabetic Retinopathy Conclave. So I would like to thank Dr. V.R. Saravanan sir and Dr. Prasanna V. Ramesh, who has taken a lot of initiative to bring his colleagues around the world to this meeting. And so I'd like to also welcome Dr. Christopher Go and Dr. Mio, as well as Dr. Arjun Shrestha for this meeting. And hand over the sessions to the chairperson and moderator. Thank you. Welcome you all.
Thank you, Dr. Balamurugan sir. So at the outset, I would like to welcome Dr. Christopher Go, who's a vitreoretinal fellow from Royal Liverpool Hospital and an associate clinical lecturer, University of Sydney, and is an adjunct clinical lecturer as well, and a good friend of mine, who will be starting with us on overview of diabetic retinopathy. Then we have lined up Dr. Mia, who's from Insin General Hospital, Burma. She's going to cover on what a general physician's perspective point of view is on. And then we have Dr. Arjun from Nepal, and he's going to talk on phenofibrinate in DR. And apart from these three speakers, I take a huge opportunity to actually introduce our star chairperson of the day, Dr. V.R. Saravanan sir. Dr. Saravanan sir needs no introduction globally, but I would just like to give a brief introduction of Saravanan sir. He's one of the high volume VR surgeons down south in India. He's taking care of the retina department at Coimbatore Arvind Eye Hospital, and he has trained many fellows and many postgraduates, as well as he's a great teacher and a wonderful surgeon. So with those three introductions, I'll hand over the session to Dr. Saravanan sir, V.R. Saravanan sir, who's our chairperson. Sir, a few words from you before we go for the first speaker, sir. Over to you, Saravanan sir. Sir, you're on mute.
Sorry. Thank you, Prasanna, for the nice introduction. And it's nice to have all the international people on board. So as we all know, diabetes is a worldwide program. It's like one of our family members. If you look at any family, at least one person will have diabetes in India. I'm not sure about the Western world, but in India, it's like one of our relatives. So it's so common, and retinopathy is a huge issue. Still not very properly addressed by the government of India, but still all the private people are doing a lot of work in this regards to reach out to the people with diabetes so that they don't lose their vision. So it's nice to have this. So, and we'll have our speakers will be elaborating on this issue so that other people can also understand the magnitude and what needs to be done to counter this big issue. Please, can you go ahead there?
Thank you, Saravanan sir. So the one thing that unites me with all the three speakers, I take this privilege to share that all three of them are doyences or young ophthalmic doyences in their respective specialities in their countries. And we got connected at the Asia Pacific Academy of Ophthalmology, where we are traveling together for the next 1 year for our LDP program. So without much time, I would like to call upon Dr. Christopher Go to have his topic on overview of diabetic retinopathy. Chris, over to you.
Thank you. Thank you for inviting me to speak on this topic. As Prasanna said, my topic is just to give an overview of diabetic retinopathy. So the aims of the webinar is just to really give a clinical overview of diabetic retinopathy. It's very basic, just going through some of the clinical signs and also the classifications. more interestingly, hopefully, is looking at some of the diagnostic equipments that are used in ophthalmology that the general physicians may not be that familiar with, and also familiarize with the acronyms and abbreviations often used by us that may come across to the general physicians in the letters and in the correspondence that are often sometimes misunderstood or not sure what's going on, and that hopefully will help in understanding what's going on. And then finally, I just gently touch on the role of the physician, and I think Mia is going to talk a little bit more about that in the next session. So diabetic retinopathy doesn't need too much introduction. I think all of us are quite aware of diabetic retinopathy. It is a microvascular end organ damage, much like other end organ damage like nephropathy, neuropathy. It's just that retinopathy is something that we can see a bit better, and also we can actually see the damages from the blood vessels. It's a common and modifiable diseases, as mentioned by the chairperson. Currently, it's estimated about 150 million people worldwide living with diabetic retinopathy, and that's about 30 to 40% of patients who has diabetes. And it's projected to be an increasing problem because of its increasing prevalence and also of the growing population, where we're estimated to have about 800 million people with diabetes in about 20 years' time. And instead of being about 1 in 10 patients having diabetic retinopathy, it's about 1 in 8 patients with diabetic retinopathy. Unfortunately, it is still the most common cause of blindness in the working age group, especially in the developed and Western world. And because it is modifiable, some of these can be delayed or even prevented. And that's why this is a topic of interest. So let's talk about a little bit about risk factors. So the duration of the disease and the glycemic control are the two most important risk factors of developing diabetic retinopathy. One study showed that after 20 years of having diabetes, about 99% developed diabetic retinopathy, and 60% of type 2 developed diabetic retinopathy. These figures may be exaggerated because it's only one study, but it does show the magnitude of the problem when the duration of disease has been there for a long time. Glycemic control is the other major risk factor. So we do want our patients to have good glycemic control, and it's reported a 10% reduction in HbA1c would delay the onset, progression, and development of severe diabetic retinopathy by about a third. Other risk factors that are important that are also may or may not be modifiable are hypertension, dyslipidemia, smoking, and then the non-modifiable things are things like ethnicity and pregnancy. So just a little bit about the classifications of diabetic retinopathy. So mainly speaking, it is split into non-proliferative and proliferative diabetic retinopathy. And then there's this gray zone where some people look at the pre-proliferative diabetic retinopathy as well. And as a sort of separate entity, we also look at macular edema. And that's basically similar sort of pathophysiology, but affecting a part of the eye that is, I guess, more important for central vision and hence treated slightly differently. So starting with non-proliferative diabetic retinopathy, sometimes it is known as background retinopathy in some literature. And the reason for that is that this is one thing that just happens in the background of retinopathy in people with diabetes. And in a non-proliferative, most of the time, we don't need any intervention. There's an absence of neovascularization, which is where the complications of diabetic retinopathy usually come from. Like any of the other diabetic complications, is related to capillary leakage and its subsequent sequelae. The follow-up interval would depend on the severity of the non-proliferative diabetic retinopathy. In mild or no diabetic retinopathy, generally speaking, we advocate for yearly follow-ups. In moderate cases, we say about 6 months, and in severe cases, 3 to 4 months' time. And this image on the left is just to show some of the clinical features happening in non-proliferative diabetic retinopathy. And those are quite some of the most common things that you will see. And this is a picture of a severe diabetic retinopathy, whereas in mild, if you don't look hard enough for it, you might actually just miss the very tiny microaneurysm that can be seen. So I mentioned earlier, there's this phase where we looked at called pre-proliferative diabetic retinopathy. Some people don't like looking at this and say that actually it's just one or the other, but it's just related to sort of more severe signs that related to chronic ischemia. So as opposed to having capillary leakage that might just get repaired with time, this is probably chronic damages and then eventually reduced perfusion and then chronic ischemia. A very high risk of developing proliferative disease. And as mentioned, it's very difficult to differentiate between very severe NPDR and early PDR. And it may be just academic to look about those two to differentiate these ones. Proliferative diabetic retinopathy, this is where we really need to intervene, and this is where it gets nasty. So it's talking about the presence of neovascularization, and that's because of the chronic recurrent ischemia leading to a lot of angiogenic factors and then leading to neovascularization. So for the retinopathy, we're looking at neovascularization of the disc and neovascularization elsewhere. But these neovascularization can also happen in the front of the eye, so you get neovascularization of the iris or neovascularization of the angle, causing glaucoma as well. Treatments are usually required in proliferative disease, and that's to prevent any blinding complications. And as mentioned, sort of in the same vein, but different entity is diabetic macular edema. It's a similar sort of pathophysiology leading to capillary leakage, but because it affects the macula, patients tend to know about it because they do get reduced vision. In a different treatment paradigm, because in non-proliferative disease, usually when it's not affecting the macula, we don't have to do any treatment. However, in diabetic macular edema, when it becomes center involving, where it becomes a worsening of vision, then these are the times when treatment is indicated. And you can see that in the images, so the top left corner image, so of the OCT, you can see that's a normal OCT of a normal patient, whereas the image below that is an image showing swelling and edema of the macula on the OCT. And as you can see, the image on the right was the same image shown on the non-proliferative diabetic retinopathy, but you can see that the macula itself in the center is involved, and so this would be considered a diabetic macular edema, and whether it's center involving would depend on the OCT findings. So treatment, so what do we do? So as alluded before already, in non-proliferative disease and pre-proliferative disease, usually we monitor and at different intervals because due to the different risk levels. In proliferative disease though, that's when treatment has to start. And the treatment options that we have as ophthalmologists are essentially laser, and that could be either pan-retinal photocoagulation, which is obliterating the peripheral retina, or we can also do macular laser in diabetic macular edema as well. Aside from that, other things that we can do are intravitreal injections, and that could be anti-VEGF or steroid injections. And then the other thing that we can do is vitrectomy surgery. And I'll go into a little bit of details on each of these things. So pan-retinal photocoagulation or PRP is usually done in about 5 to 8% of patients with diabetic retinopathy. The rationale for that is to obliterate the ischemic peripheral retina to reduce the VEGF production and to promote neovascularized regression. And that's to essentially allow to preserve the central vision in sacrificing the peripheral vision. With PRP though, it can initially reduce visual acuity because of the development of diabetic macular edema, and that's something that we usually have to warn patients about. Otherwise, they often say, oh, the laser caused my vision to get worse. And because of that, some people actually give anti-VEGF before they do PRP, if that's something that's available in the institution or affordable by the patient. Anti-VEGF is shown to have similar outcomes as PRP. However, it will require more frequent clinic visits and has less permanent effects than PRP. And therefore, as retinal specialists, what I usually advocate is to maybe tie over using anti-VEGF, but more permanently do PRP. And the reason for that is that these patients often are non-compliant with their follow-up, or have other medical appointments that clash, and then they may miss their anti-VEGF appointments, and then that may lead to blinding complications. However, if you do a PRP, then that's less likely to happen. Vitrectomy. About 5% of patients with diabetic retinopathy will require vitrectomy, and the indications are usually because of blinding complications like tractional retinal detachment or persistent vitreous hemorrhage. Other things that might require vitrectomy in diabetic patients are things like macular traction with edema or epiretinal membrane as a result of their diabetes. The aim of vitrectomy is to remove the pro-angiogenic factors. That's by removing the vitreous, and to remove the traction, which is the delamination, the segmentation that we often see in our reports. And that's to essentially get rid of the traction and that's coming from the vitreous and any proliferative membranes that might cause a retinal detachment. So what does this all mean for you guys as physicians? Well, the main thing from my point of view is that the physician is very important in the prevention and promoting screening for diabetic patients. I do not expect you guys to be able to detect or diagnose patients with diabetic retinopathy. However, it would be great if you advocate for them to have yearly checkup or more frequent checkup if requires. More importantly, also, it would be to understand the severity and the implication of the disease, and as a multidisciplinary approach to advocate and educate the patients about the conditions to hopefully make them more compliant with the treatment and follow-ups. So screening, how do we screen? I don't expect the physicians to be able to screen, as things like visual acuity and direct ophthalmoscopes are probably too primitive for screening in diabetic retinopathy. I would say minimum requirement would be a standard fundus photography, and there's an increasing use of wide field fundus photographs, and I'll show you why. So this is the view you would get if you're lucky with a direct ophthalmoscope. This is the view you would get on a standard fundus camera, and you can see that there's hard exudates and maybe some microaneurysm. However, if you do a wide field images, then you can see that the problems is much more severe. And then if you actually do other imaging modality like a fundus fluorescein angiogram, you can see that this is actually a proliferative disease with areas of non-perfusion, and this patient will actually need PRP to treat the patient. And that's the reason why it requires regular screening and also eye care professionals to examine these patients. So why should we screen? The reason for that, as you can see, is that the risk profile of each of these are very, very differently. So you have no diabetic retinopathy, there's less than 2% chance of developing into a proliferative disease. And then as you increase and become more and more severe, it becomes a much higher risk of getting a severe retinopathy, up to 50%. And why do we care about that? Because in 50% of untreated proliferative disease, it gets blind within 5 years. And these are the reasons why it's with tractional retinal detachment, as you can see on the left-hand side, and on the right-hand side with vitreous hemorrhage, and also potentially a retinal detachment down the bottom here as well. So the take-home message is that this is a very potentially blinding disease. Prevention is through glycemic and comorbidities control, which is where you guys come in as physicians. And finally, screening is where it allows for early intervention and will prevent, hopefully, the blinding complications. That's it. Thank you.
Thank you. Thank you, Dr. Chris. Over to Saravanan, sir, for your comments, sir.
Excellent talk by Dr. Chris. He had totally covered the various stages and exactly mentioned what is expected from a general physician or diabetologist, what they need to do and when they need to refer. So it's even though it's been concise, he has clearly given the message across what needs to be, what is expected from a general physician and a diabetologist, what needs to be done, and also the magnitude of the problem and the need for proper screening. So I think if there are any questions from the other panelists, then we can go ahead or we can go to the next talk.
Do we have any other questions from any other attendees? So you can keep posting your questions here in Zoom, or you can keep posting it in YouTube as well. So we'll be able to pick up your questions, and then we'll also be able to put it forth to Saravanan sir, as well as our 3 international faculty. So Chris, do stay with us. We have 2 more talks, and if there are any more questions, we would love to love you and the others to take the questions as well. Saravanan sir, yeah.
Yeah, no.
Can we move to the next
Yeah,
speaker?
definitely.
Yes, sir. So with that, we move to from overview to screening for general physicians. So a diabetic screening for general physicians. I'd like to call upon another good friend of mine from Burma, Dr. Mia. So she's in Insane General Hospital, and she's going to cover us or to cover the topics of what a general physician expects. Over to you, doctor. Yeah, your screen is visible.
Okay.
Yeah.
Can
Perfect.
you hear my voice?
Yeah, audible, loud and clear.
Okay. Hello, everyone. I'm here. My name is Mia. I'm currently working in Burma as a retinal specialist. I'm here today to talk to you about the screening of the diabetic retinopathy for a general physician. Okay, let's start with the prevalence. Diabetes remains a leading cause of legal blindness between the ages of 25 to 65 years in the Western world. The total number of people with diabetes is raised from 285 million in 2010 to 578 million people in 2030. The prevalence of DRN diabetes is 421 million in 2021, but is raised to about 161 million in 2045. So it is responsible for 1.8 million of the 37 million cases of blindness throughout the world, which is about 4.9%. 33% of the patients with diabetes have signs of diabetes retinopathy. So DR is common in diabetes patient. This chart shows the prevalence of the DR in diabetes patient. For my country, Burma, it's about 34% of DR in diabetes patient, which is about 23.5% of the vision-threatening condition. It's quite high. For the urban Indian, especially in Chennai, is about 17.6% DR in diabetes patient, and what is about 1.4%. For rural Indian, 10.2% of DR in diabetes patient, which is about 2.4% of the vision-threatening condition. There's a high prevalence of undiagnosed diabetes worldwide. So screening of DR cannot be restricted to people with no diabetes. It is recommended that DR screening can be done for all people with no diabetes on treatment. A single record of random blood sugar of more than or equal or 200 milligram per deciliter, hemoglobin A1C more than 6.5% or higher, or gestational diabetes when first notified to a medical personnel in clinic or community center. Although at least 2 laboratory test results are required to prove that an individual has diabetes, but we recommended that at least single laboratory test to be performed to screen for diabetes due to the urgent need to identify and treat the patients to prevent the blindness due to diabetes. The gold standard for grading the severity of the diabetic retinopathy is stereoscopic fundus photography through dilated pupils using the 7 standard fields and grading guidelines for those photographs established by the ETDRS group. This is a ETDRS classification for diabetic retinopathy. So it can be categorized into the non-proliferative type and proliferative types. So I think Chris already mentioned the classifications of the diabetic retinopathy in his presentation. So this is a fundoscopy image of mild and moderate diabetic retinopathy. For mild type, you can also see the microaneurysm or small dot and block hemorrhage. For a severe type, moderate type, there's also the heart exudate and microaneurysm block hemorrhages. These photos show the stages of the diabetic retinopathy from early to PTR and neovascularization stage. You can also see the laser scar and also the dot block hemorrhages in PDR and neovascularization stage because of the PRP is already done. So this is early and advanced stages of the diabetic retinopathy. You can see the hemorrhages, vitreous hemorrhage, traction bands, and also the PRP scar in advanced stage. So what are the signs of the macular edema? Macular edema includes any of the following signs, which is a retinal thickening at or within 500 micrometer of the center of the macula, or retinal thickening of 1 disc area or larger in any part of the retina, which is within the 1 disc diameter from the center of the macula, or high exudate at or within 500 micrometer of the center of the macula. So this photo shows the diabetic macular edema. You can also see the hard exudates surrounding the macula. And this lower part of the photo shows the very severe macular edema, and it corresponds to the diabetic macular edema in OCT image. So how often would you screen the diabetes patient for retinopathy? For type 2 diabetes, it should be screened annually. For type 1 diabetes, who is newly diagnosed, no screening for the first 5 years. For the type 1 diabetes, 5 to 10 years from initial diagnosis, it should be screened annually. For type 1 diabetes, with more than 10 years after the initial diagnosis, it should be screened every 6 months. When will you refer a patient with or without diabetic retinopathy? It depends on the state of the retinopathy. So there's no diabetic retinopathy. It can be referred within 1 year to ophthalmologist. For mild NPDR, it also within 1 year. For moderate NPDR, it should be referred within 3 to 6 months. For severe and proliferative DR and also the diabetic macular edema, there's need of urgent referral to an ophthalmologist. Current screening program in Asia Pacific region, for my country, Myanmar, current screening program, there's none, although pilot program found a high incidence of the vision-threatening DR in the provisional area of Myanmar. For Jakarta, 84.7% of the DR patients have not underwent a yearly eye exam. 49.4% of the DR patients were told to get an eye exam. For Nepal, limited regular community DR screening programs and are provided mainly from tertiary eye hospitals. Fundus photos are taken by ophthalmologists and graded by retina specialists. For Malaysia, 44.7% of the DR patients have not underwent a yearly eye exam. Guidelines set for community diabetes fundus photograph to be taken with trained human graders. For Sri Lanka, direct ophthalmoscopy examination by primary care doctors. For Pacific Islands, no screening program rely heavily on visiting teams of eye doctors to perform the screening. What is the relationship between the diabetic retinopathy and pregnancy? A retinopathy can progress rapidly in pregnant patients with pre-existing diabetes. Careful and more frequent evaluation is indicated in every trimester and immediately after the pregnancy and during a year postpartum. So the gestational diabetes is not associated with retinopathy. So regular evaluation is not indicated in this group of patients. In summary, DR can occur in type 1 and type 2 diabetes. Increasing diabetes duration increase the risk for retinopathy. So educate the people with diabetes that early stages of DR are symptomatic, and so screening for DR is essential. Routine, repeated, lifelong, expert, complete eye examination is essential for the fundamental care of all people with diabetes. Annual screening may be performed by telemedicine or by on-site fundus photography. Opportunistic screening for DR may be done in the community through camps, at diabetic clinic, medical laboratories, but DR registry should be maintained for annual recall. Fundus photography can be performed by trained technicians, and grading of DR can be performed by certified trained eye technician, general physician, endocrinologists. Women with pre-existing diabetes who are pregnant or planning a pregnancy should be counseled regarding the risk of development and progression of DR. If any level of DR represent in any examination, opportunistic screening, systematic referral to ophthalmologist must be done. Prompt referral of patients with diabetic macular edema, severe NPDR or PDR to an ophthalmologist, retina specialist for further management of sight-threatening DR. The gold standard management of PDR is by PRP, and standard involving DME is by intravitreal VEGF. Non-standard involving DME focal laser therapy and regular follow-up is essential. Nationwide diabetes and DR registry is essential to ensure monitoring of compliance with referral and follow-up. Impact of DR screening and management of blindness can only be monitored by maintaining DR registry. Use information technology to store fantastic image reader and application of AI in DR detection could be way forward in telemedicine screening of DR. Good glycemic control and control of other systemic factors is beneficial in any stage of DR. It delays the onset and slows down the progression of DR. Diabetes in general and DR are lifelong conditions. Regular follow-up care with a physician and an ophthalmologist is crucial for early detection of complications and benefit from timely treatment. These are my references. Thank you. This is my end of presentation.
Thank you, Dr. Mia, for taking over from where Chris left, and I would like to pass on to Dr. Saravanan sir for his valuable feedback and comments.
Again, very nice talk by Mia. So each country has their own limitations on how to go on screening of for diabetic retinopathy. The sheer magnitude on the number of patients and the availability of the vitreoretina specialists who can do the screening does not coincide. Like we have very few people who can screen, and the number of people to be screened is quite high. So she has just touched upon what are the various modalities by which we can overcome this problem. Because like unlike cataract where we do one-time surgery, this needs to be done frequently over the years. The job is huge and the number of people who can do this job is less. So probably AI-based telescreening as well as other forms of modality of like we have our own satellite screening systems. So person-to-person screening by the ophthalmologist or the retina specialist is not possible with such a big patient population. So she has clearly mentioned about that, and a lot of people are exploring on various avenues on how to address the magnitude of this problem. Nice talk by Mia. Thank you.
Yeah, so we are getting some questions here. So we have one question from Dr. Gauri Shankar. So he's asking how to screen for DR in a general OPD for diabetic patients with limited resources.
So that's what she was also mentioning. It's probably it's not possible for the diabetologist to do the screening per se. So best option for in a non-ophthalmologist clinic is to do a photographic. We have handheld cameras also. So we have both AI-based camera based like you have the in India we have the machine AI, like not on cloud, machine-based AI, where immediately once you take a photograph, it gives a comment on what's the status of the so handheld cameras and proper cameras where you can send the images to a telescreening reading center. So all these are all possible modalities. So person-to-person screening as I told is not possible. So telescreening option where you send the images transmitted through broadband or satellite to a reading center, or AI-based either cloud like Google, cloud, we have Google also available, cloud-based AI or a machine-based AI like the Remedio handheld camera system. So these are options. Remedio, I feel, is the most cheapest and easily available without any cloud access. You can do it without even in the periphery in a camp setup where there is no internet options. You can do the Remedio handheld cameras. So these are possible options which we can look at in an Indian scenario. Probably, as Mia already told, each country has their own problems and restrictions. So this may not be holding good for another country, but for India, especially Tamil Nadu, I feel Remedio is one very good option because the camera is also handled easy to carry over through to all the peripheral centers. The Kerala government has purchased the license from Remedio and they are using it for their rural diabetic retinopathy screening in primary health centers by a trained technician, not a doctor, by a trained technician. So that is one of the options which has been quite popular in South.
Thank you, sir. So we have another question for
Mia wants to add on the point, I think.
Yes, sir. We have another question for Dr. Chris and Dr. Mia. Any one of you can go for it. So what are the latest gadgets to screen diabetic retinopathy? So what is latest and buzzing? Chris, what are the latest?
You are muted. Yeah.
I don't think that there are any sort of new technology in terms of gadgets. I think the main new thing is AI that's coming. More and more people are using AI as a means of screening, but in terms of actually doing the screening itself, I think we're still using the same cameras and the same equipment from that.
So what about in India? Are you using the AI?
Yeah.
Right now, I told you one of the states in Tamil in South India, the Kerala, the government they are using it in their peripheral centers where there is no ophthalmologist. So they have started this in their primary health centers where there is no ophthalmologic services. So they are trained nurses, ophthalmic nurse, general nurses to do this using the Remedio handheld camera. It has inbuilt AI, not a cloud-based AI. It's an inbuilt AI, so there's no need for a network access also, internet access also.
Thank you, sir. Dr. Arjun, do you want to answer any of the questions? So we have another one. I think any one of you again can take it. It's quite simple for an ophthalmic point of view, but very important for a diabetologist or a physician point of view. How to differentiate glaucoma symptoms and diabetic retinopathy symptoms?
So glaucoma and they're totally different. I think the vision tends to be quite clear, central vision in glaucoma. Only in advanced stages they start losing their central vision. Whereas in diabetic retinopathy, especially in type 2, most often it's the central vision which starts to suffer because of the macular edema. So they are totally different diseases, and vision tends to be quite normal in even in advanced glaucoma till the vision becomes the glaucoma damage becomes very severe. Whereas in diabetic retinopathy, it is sort of reverse actually.
Thank you, Saravanan sir. Thank you, Mia. Thank you, Chris. So moving on to the last speaker of this International Diabetic Retinopathy Conclave, I would still request all the other three to hold on to answer and get the questions coming from the participants so that we can have another round of discussion at the end, and Dr. Saravanan sir and the panel will be giving their closing comments. So next I would like to introduce Dr. Arjun from Nepal, again a good friend of mine who got introduced to me at the Asia Pacific Congress. And Dr. Arjun is going to talk on phenofibrinate in diabetic retinopathy. So over to you, Dr. Arjun, for your talk on one of the recent advances. Saravanan sir, is it a recent advances or is it something that is?
It has been there for some time. Probably because initially it was very popular a few years back, and then it went to the back burner. I'd like to hear what's the current scene in Nepal, at least in India and Tamil Nadu, at least. It's not talked about much. There was a period of interest a few years back. It was very popular. Everybody was talking about it, and then suddenly it went to the back burner. I would like to hear any new information on this.
Super. So over to you, Dr. Arjun, for your talk on phenofibrinate.
Okay, good evening, everyone. So I feel very privileged to talk on this international conference on diabetes here. So let me go to the topics: phenofibrinate and diabetic retinopathy. The next slide, please. Yeah. We know that there are treatment options are available in diabetic retinopathy, and that they are laser photocoagulations, intravitreal anti-VEGFs, pars plana vitrectomy. But these treatment options are not so easy. So next slide, please. So actually, these treatment options are available and usually safe, but not free from complications. And they are more invasives. Lasers can cause scotoma and peripheral vision loss. And injection and surgery, they can cause infection sometimes. And moreover, they are expensive. Usually, the patients, they have to come every month to have injections if they have diabetic retinopathy in most of the patients who visits with visually symptomatic patients. So the other things is this treatment option, when we tell patients that you need lasers or you need injections, you have to visit many times in hospital, then patients are, very anxious, and it's stressful to patients. So these are the concerns that we have to think over for while treating diabetic retinopathy. Next slide, please. And as we know that standard of care is control of ABC, good control of blood sugar level, blood pressure, and cholesterol. But whatever we control all these three parameters, but retinopathy, once it starts, it is not going to stop. But we can just delay the progressions. We cannot stop it. So that's the problem. So we have to think holistically. Next slide, please. So we have to seek alternatives to prevent diabetic retinopathy. Next slide. Now then here comes about the fenofibrate. Actually, for diabetes chain or diabetes physicians, fenofibrate may not be their choice, first choice in lipid lowering agents. Statin is usually the first choice for them because it has some cardioprotective effects as well. And this fenofibrate doesn't have so much cardioprotective effects. That's why it's not so commonly used. And actually, it reduced the progression of diabetic retinopathy by two major studies that I'm going to tell in next few minutes. And sometimes, because despite our this conventional treatment like intravitreal anti-VEGFs, lasers, everything, patients' symptoms or patients' disease severity may not improve. In that case, we ophthalmologists are usually confusion that how can we improve their vision or their disease conditions and diabetic retinopathy. In that scenario, then probably fenofibrate might help in reduction or introduction of progression of diabetic retinopathy. Next slide, please. So what is fenofibrate? Is a peroxisome proliferative activated receptor agonist. Next slide. So how does it works in diabetic retinopathy? Actually, is it definitely lowers the lipid level, but the beneficial effect in diabetic retinopathy is not through lipid lowering effect, but several mechanisms have been proposed. And one of the first is it is known to increase the level of circulating apolipoprotein A1, which has recently been shown to be an independent protective factor for diabetic retinopathy development. And also it regulates intraretinal level of lipid metabolism, and it reduces the lipid deposition and lipotoxicity. And it acts as anti-apoptosis, antioxidant, anti-inflammatory, and anti-angiogenic activity. So it has protective effects on blood-retinal barrier breakdown. Next slide. So I'm going to just recall two major studies that was done few years, not few years, let's say maybe 10 years back. The first one is field study, FIEL field, fenofibrate intervention and event lowering in diabetes. It was 5 years prospective multicentral randomized controlled trial studies. It was done in Australia, New Zealand, and Finland. And here there was investigation of effect of fenofibrate 200 mg per day among 9,795 patients with diabetes mellitus type 2. And in the baseline, there were 8.3% patients had already diabetic retinopathy. Next slide. So what finding was there in terms of diabetic retinopathy prevention or prophylaxis in this fenofibrate intervention trial was fenofibrate treatment was associated with a reduction in the need of laser treatment by more than 30%, over 31% overall. So for those patients who were taking fenofibrate at pure need of laser photocoagulations, we need laser photocoagulation for diabetes macular edema and proliferative diabetic retinopathy. But patients who were taking fenofibrate, they were more protective for, they have more protective effects, and they needed pure lasers photocoagulations. But the limitation of this study was their primary goal was not to find out the role of fenofibrate in diabetic retinopathy, but their primary objective was to find whether it works for as a cardioprotective effect, whether it decreases the mortality from cardiac risk factors, something like that. But actually, these drugs didn't help much to protect cardiovascular risks. But in tertiary point of view, it had a significant amount of lower need of laser photopopulation. Next slide. So this beneficial effect of fenofibrate in terms of reducing the requirement of laser treatment for either macular edema or proliferative retinopathy were apparent at 8 months of therapy, with progressively greater benefits accumulating with time. Interestingly, level of total LDL, HDL cholesterol, as well as triglyceride were not different between patients requiring laser treatment and those who were not taking laser treatments. So this could be the facts that these drugs might work by another mechanism, not as a lipid lowering mechanism, by another mechanism that I described already. Next slide, please. So there were field ophthalmology sub-study group also, and there were 1012 patients, and they had standardized retinal photographs that were graded according to ETDR's criteria to determine the incidence and progression of diabetic retinopathy. Next slide. So among patients with pre-existing diabetic retinopathy, significantly fewer patients in a fenofibrate group, they experienced a 2 steps vision loss compared to those in the placebo group, 3.1% versus 14.6%. So patients taking fenofibrate groups, they lose visions less compared to those who didn't take. So incidence of new diabetic retinopathy was not different between the fenofibrate and placebo group. So it means this study showed only it helped to reduce the progression of disease, but not the incidence. Next slide, please. So this was another major study. It was also randomized controlled trial done in supported by National Institute of Health, and action to control cardiovascular risks in diabetes. And it was 4 years prospective study. Here they compare the effectiveness of simvastatin plus fenofibrate versus simvastatin plus placebo. So in this case, in this study, the addition of fibrate to statin decreased kidney damage, foot ulcer, and diabetic retinopathy in mild and PTR. In 4 years, what they found is 12% of control groups, they progressed to 2 or more lines in ETDR's visual acuity, while 10% of statin and 6.5% of statin and fibrate group lost 2-line vision. So this study also showed that adding statin, it helped to decrease the prevalence of progression of diabetic retinopathy. But the limitation of both these studies, both field study and accord study is, first, when interpreting the finding and clinical implication, it is important to remember that diabetes was not a primary endpoint by design in either of these studies. So it was tertiary endpoint in this study. Second, neither the field nor accord eye studies saw improvement in visual acuity outcomes, despite showing a reduction in diabetic retinopathy progression. And third, neither study used a quantitative measurement of diabetes macular edema, such as optical coherence tomography, that we use now commonly. It was not used in that time. Next slide, please. So it was approved in Australia because this field study was actually done in Australia, New Zealand. So as soon as the finding, there was a favorable finding from field in 2013, Australia was the first country to approve fenofibrate in the treatment of diabetic retinopathy. So probably Dr. Chris might tell something about this later. But we haven't found that this drugs was used in many countries, including our country. Also, we also don't use this medicine is not used. But probably we have to think from the lesson from Australia that could be helpful in the prevention of to help the progression of diabetic retinopathy. Next slide, please. So our academy, American Academy of Ophthalmology, also do not mention anything about fibrate in diabetic retinopathy management. But American Diabetes Associations, they suggest collaboration between ophthalmologists and diabetes physician to consider fibrate for people affecting with diabetes. So they just suggest that can be considered in the treatment of diabetic retinopathy. Next slide, please. So key point is there is firm evidence that fenofibrate shows the progression of diabetic retinopathy and reduces the need for laser photocoagulation and vitrectomy surgery. But it doesn't replace the need to maintain appropriate control of blood sugar, blood pressure, and lipid profile. Serum creatinine and liver transfer needs to be monitored while patient is on fenofibrotherapy. And sometimes, although rare, myopathy and rhabdomyolysis can occur, and we should have patients should be aware that they should seek prompt medical attention if symptoms of muscle pain, tenderness develop. Next slide. So in conclusion, the addition of this fenofibrate may have significant public health benefits in reducing the progression of diabetic retinopathy and the need for more expensive and invasive treatment modality. So our current scenario, anti-VEGFs are available, vitrectomies are available, laser is available, but these are very expensive, and as I said, that they are invasives, and moreover, patients are very anxious in getting long treatment with diabetes. So we have to focus on prevention. If fenofibrate helps, and it has been used in Australia, probably other countries might also have to think as additional alternatives in the prevention of diabetic retinopathy. In our clinical scenario in Nepal and probably in India also, we might think sometimes, despite our management with anti-VEGFs, lasers, everything, patients may not get benefits. So we also know that patients vision is not improving, their findings is not improving. Then we think that could be fenofibrate if we use, they might help in future. So this is my end of presentations. Thank you.
Prasanna, you're muted.
Thank you, Dr. Arjun. Dr. Chris, your experience, which Arjun just wanted you to touch upon, and followed by Dr. Saravanan sir's comments. Yeah.
So I think with the fenofibrate, it's such a small subset of patients that are shown to be effective in slowing diabetic progression. It's often what we normally say to physicians are basically, if you think they need fenofibrate, go ahead with it. But I don't think it makes a huge difference.
I think we just lost Chris there a bit. Saravanan sir.
Yeah. Thing is, like as already pointing out, there was a lot of interest some years back, but as the last penultimate slide which he showed, Dr. Arjun, there are some issues, like even for a diabetologist or a general physician, fenofibrate is not the first choice for lowering lipids. They usually go for statins, which is much more safer and much more preferred. So also in India, like the ophthalmologists do not work hand in hand with the diabetologists. There are very few centers who have a in-house or who have a close bonding between ophthalmologists and diabetologists or general physicians. That bonding is lacking. So as such, this cannot be prescribed directly by an ophthalmologist. And when you don't have a interdisciplinary good communication, I'm not sure whether this the current role in India, I'm not very sure. Plus, the data on the efficacy of fenofibrate in controlling or helping diabetic retinopathy per se is not that very robust. That's one of the reasons why it has not become very popular. So even though there are some studies which are showing the evidence is not that very robust where everybody can take it up and follow. Like in Australia, they are doing it regularly. That was news to me. But in other countries, I have not seen fenofibrate has not been showing that much. I mean, ophthalmologists have been showing not much interest in this molecule, this tab.
Chris, we just lost you there for a bit. Can you just complete what we are about to say?
Yeah, so I was saying the general consensus is that we don't advocate for physicians to
Again, he's lost.
From our point of view, I don't think it makes a huge difference.
Dr. Mia, Dr. Arjun, do you want to add anything else? So we have a couple of minutes more before we hand over the session to the cardiology team. So Dr. Arjun, Dr. Mia, anything else that you want to add on from a physician's point of view?
Prasanna, I'd like to ask the other panelists, general physicians and cardiologists, like what is their view on how popular is fenofibrate compared to statins, and how often they use, and what are the indications which they use for in diabetic patients? Like if they can chip in, like I would also get an insight on how popular and how where it is used.
Yes, sir. We do have another panel set coming in, but I'm not sure
Oh,
whether
Dr. Prasanna
yeah.
and Dr. Suresh, are you online? Dr. Suresh?
Yes.
Hey,
Dr.
Bala.
Suresh?
Yes,
Yeah.
yes, I'm online. I think I heard the
Yeah.
question,
Yeah.
and if I can repeat the
please.
question, the question's about fenofibrate, right?
Yes, sir. Yes, sir.
So I would say in at least in North America, fenofibrate is being used, but I'm not convinced that the data is that strong that it's used that regularly for diabetic retinopathy and stuff like that. Statins, absolutely yes, but fenofibrate, probably no.
Okay, sir. Thank you.
Thank you.
Dr. Venkatraman sir, are you there? So for some unknown reasons, the fenofibrate is not much popular. And not the reason being the side effects also. Basically the muscle related side effects are also, and some liver related issues also can occur with the fenofibrate. So that is one of the reasons I think, basically in medicine and cardiology and diabetes, fenofibrate is used to address the triglyceride reduction. So by addressing the triglyceride reduction, if it's going to be worth in modifying the diabetic retinopathy, my good friend Dr. Suresh said that he is not in far, but as he said, there are a lot of evidence is with more robust evidence with statins than with fenofibrate. And
Bala, the other thing we use now is also, I think it's called Vasipa, which is high dose fish oil. So the idea is to use, a really concentrated version of fish oil for triglyceride reduction in addition to statin therapy. So that's the other reason, and there's now more evidence coming from that front rather than from fenofibrate. So you're right, Bala, in saying in terms of liver and in terms of the combined effect of both statin and fenofibrate on liver toxicity, that's the other reason we don't use much of it. So anyway, thank you.
Thank you. Thank you. Thank you for the information.
Thank you, sir.
Bala, can I just, this is Dr.
please step in,
Venkatraman.
sir. Yeah.
Good evening at the outset. Congrats, Bala. Yeah, I think very, very nice discussion. In fact, I think the fenofibrate, it's the usage has been limited by some. I personally feel lot of perceived issues with the fenofibrate. Number one. Number two, in the Indian context, I think Bala will agree that we have the opportunity of using another powerful molecule for triglyceride reduction, that is saroglitazar. So, but unfortunately, outside India, I don't think they have the experience. And recently, we did have a paper in our journal club, if I remember right, on fenofibrate with respect to renal disease. I think, contrary to what we expect, probably it can offer some benefits, even though initially there's a small rise in the serum creatinine. Like some of these parameters do have an upward trend within the permissible limits when you exhibit a molecule. So even though the final word is not set, and since there is a molecule and some soft evidences are there, so triglyceride as a target, certainly for the macrovascular disease by itself, I think there is a divided opinion. Maybe we tend to believe that it has to be targeted, as the Lipid Association of India has issued the guidelines based on some evidences. With respect to microvascular disease, possibly there are some soft data with respect to nephropathy. Retinopathy, I'm not too sure. As I told you, there is certain amount of reservation, at least among the endocrinologists and physicians, to use fenofibrate in a larger scale. That's my thought, my brief thought about fenofibrate.
Thank you, sir. Great.
Venkatraman sir, we have Dr. Saravanan, who is the retinal surgery head from Aravind Hospital, Coimbatore. He is only chairing the session today, sir. And we had 3 speakers. One
Okay,
from
sorry, I joined very late, Bala. I'm sorry,
Yeah.
just now because
we
of
have three
issues.
speakers,
Saravanan.
international speakers.
Hello, sir. How is it?
Speakers. Hi, Dr. Suresh. It's so nice to listen to, of course, in bits and pieces of your presentations. I apologize for my late entry. I plan to.
No, I'm actually going to start talking now, so you can listen.
Okay, good.
Yeah.
Sure.
And
So can you see my slide? Can you see my title slide?
Yes, sir. Yes, sir. Yes, sir.
Okay, great. So
So just a moment, sir. So before we hand over the session to the next set, I would like to request Dr. Chris, Dr. Arjun, and Dr. Mia to have any closing comment on this particular lecture before we go to Dr. Saravanan sir's comment. Dr. Chris, Dr. Mia, and Dr. Arjun, any last comments from you before we hand over the session?
Nothing from me.
Yeah.
Yeah,
Yes,
and nothing for me as well.
yeah. Then we'll move to Dr. Saravanan sir. Sir, your
Yeah,
closing
that
comment?
was very nice talks by all the 3 speakers, quite good. And there was a last question whether we can use fenofibrate in patients with diabetic macular edema and PDR in routine practice. But as already pointed out by all the discussions, that the evidence currently is not that very robust to warrant standard protocol for using fenofibrate in patients with either diabetic macular edema or proliferative disease. But otherwise, a great effort by Prasanna and the Cupid group. Thanks for inviting me. It was great attending this session. Thank you.
Thank you, Saravanan sir, and thank you, Chris. So we had 3 speakers, one from Australia, one from Burma, and one from Nepal. And thank you, each one of them, for generating much interest. And without much ado, I would like to pass on the session to the International Cardio-Diabetic Symposium team of Cupid. I welcome Dr. Suresh sir, Dr. Merlin, Dr. Vaidyanathan sir, and Dr. Venkatraman sir. Sir, so over to you for the cardio.
Thank you very much, the Retina team.
Thank you.
Retina
Thank you.
team,
Thank you so much,
Dr.
sir.
Saravanan sir, and thank you, Dr. Prasanna. And
Thank you,
sir, we are moving on to the cardiology session, International Cardiology Symposium. And I'd like to welcome Dr. P.R. Vaidyanathan sir, Senior Interventional Cardiologist of Coimbatore, and Dr. Venkatraman sir is our professor in diabetology, one of the very well knowledgeable physician and diabetologist in the country. Same way, Sir Vaidyanathan sir also got almost 30 years of experience in cardiology. And now handing over the session to Dr. Vaidyanathan sir to introduce the speaker and speaker.
Yeah. Good evening, all of you. Dr. Suresh P. Damodaran is going to talk on diabetes and heart, a cardiologist perspective. He is the president of American Heart Association Midwest and is working in Women's Heart and Vascular Institute, Kentucky, USA. Has a lot of work on his own, and basically he is going to give you an idea about where does diabetes stand. We all know, we have learned, see, diabetes and vascular disease are inseparable. And from third year onwards, we have always studied that diabetes is one of the risk factors like hypertension, dyslipidemia, etc. But we have come to understand now the whole spectrum of risk factors usually clustered together because they have single etiology like the insulin resistance, which is responsible for diabetes, abnormal lipid profile, as well as hypertension, because most of the diabetics develop hypertension over 4 to 5 years, or you are a hypertensive, you will develop diabetes over 4 to 5 years. The presentation of diabetics with heart disease is different. Manifestations are different. The response to treatment are different. And you should be worried when you see a diabetes with heart disease because there is an increased morbidity and mortality. And most of the time, the mortality or loss of life in a diabetes is due to a heart disease rather than hyperglycemia per se, unless you have sepsis. So with this, let us listen to an authority on heart disease and diabetes, Dr. Suresh.
Thank you. Thank you so much for your kind words. I think you gave a great introduction in terms of where diabetes sits in terms of vascular disease. And most of you know over the last few years, when we look at diabetes, we're not looking at just hyperglycemia. we are not just looking at diabetes as vascular disease, but actually diabetes is a continuum of cardiovascular, kidney, and metabolic syndrome. So the idea is the AHA has come out with a scientific statement now, so defining what the cardiovascular, kidney, metabolic syndrome really is. And when you look at it, most of us know cardiovascular, kidney, metabolic syndrome. Indirectly, that means diabetes, right? Most of patients with diabetes at some point in time will develop these three things. They will have some vascular issues, they would have issues with their kidney, and of course, it's a metabolic disorder. So a systemic disorder characterized by interactions among metabolic risk factors, chronic kidney disease, and the cardiovascular system, leading to multi-organ dysfunction and high rates of adverse cardiovascular outcomes. What this terminology means is, as a practicing cardiologist, most of us know that a patient with diabetes is equivalent to somebody who's already had a cardiovascular event, meaning it's like you're treating somebody with a heart attack in the past, and that person has diabetes in addition to it. So the idea is a cardiovascular patient with diabetes is a cardiovascular patient who already has documented cardiovascular disease. So the idea is to look at this not purely from the cardiovascular or the coronary disease angle, but to look at the global cardiovascular risk of the patient. Now, 30 years ago, when I left India, came to North America, and having spent time here, I can tell you that the ramifications of diabetes in every part of the world are pretty much the same in terms of the extent of vascular disease, the increased incidence of heart attack and stroke, the increased incidence of peripheral arterial disease, all of which are interrelated to diabetes in some way or form. So when you define CKM syndrome, you can see that it's a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity, leading to poor health outcomes. Just a few words. Most of us know heart disease is the #1 killer in India now. Kidney disease, unfortunately, is also catching up. There's a lot more kidney disease that's undiagnosed in India. And hopefully with the education, more and more people will realize about kidney disease. There is a huge explosion of diabetes, not just in India, but also in South India, with the increased incidence of obesity, which is happening very commonly now in 20 and 30-year-olds in India, who all in some way or form have a very high incidence of insulin resistance, which is prevalent in the population. And unfortunately, insulin resistance in some way or form is a precursor to vascular disease. And that's something that we are going to see more and more in time. So when you look at the cardio-kidney metabolic syndrome, you can see that a lot of patients with diabetes also have hypertension. Hypertension and diabetes in some way are brothers and sisters. And most patients who have hypertension and diabetes also develop dyslipidemia, which is either hypertriglyceridemia or high LDL levels and low HDL levels. And all of this combined go together with the formation of the metabolic syndrome. And with presence of metabolic syndrome, the first thing that happens is, most of us know, with the higher incidence of these three things, there's high incidence of oxidative stress and inflammation. And inflammation is one of the key markers of diabetes, and it's present at many levels, leading to various harmful effects on the kidney, on the brain, on the peripheral arterial system, so on and so forth. In addition to that, most of us know diabetes affects the kidneys. You have both glomerulosclerosis and you have interstitial disease in the kidneys, all of which leads to chronic kidney disease. And in some way or form, the heart gets involved very clearly because of increase in hormonal systems or neurohormonal activation with the renin-angiotensin system, with the endothelin system, with various systems that are affected, which then has an effect on the heart. And that leads to more worsening of atherosclerosis and increased risk of having plaque rupture, which leads to acute MI. And at the same time, there's a higher incidence of heart failure or LV dysfunction that happens in the diabetic patient, all of which forms a syndrome. And finally, you can also see that the excess dysfunctional adipose tissue that's present in the body, predominantly in the stomach, which is the reason for high incidence of insulin resistance in South Asians or South Indians. So as I was mentioning, there's excess morbidity and mortality beyond the sum of its parts. And that's very, very important for us to realize that diabetes per se may not kill, but diabetes kills in many other ways. It kills the heart, it kills the kidneys, it kills the brain. So indirectly, our effect is to say the morbidity and mortality is beyond the sum of its parts. Finally, there's mechanisms by which we could hopefully treat some of these things. And in the subsequent slides, there's a classification which we will talk about. So chronic kidney disease as an amplifier of cardiovascular risk. So when you look at diabetes, most patients with diabetes at some point in time will develop an albuminuria, which will develop some amount of glomerular disease, which is an early marker of chronic kidney disease. And once chronic kidney disease happens, it's already affected the cardiovascular system in a big way. And it's an early cardiovascular risk factor. And most of us don't recognize the cardiovascular risk early on in a diabetes patient, because unfortunately, just like hypertension, patients cannot find out they are hypertensive. We as healthcare providers, either by educating our communities, our students, or our community at large, we are the ones who need to teach them that high blood pressure is very inherent because of the lifestyle risk that's happening in India now more so than ever. And along with hypertension, people develop, increased insulin resistance, and finding diabetes, it takes probably 5 to 10 years by the time somebody's blood sugar is elevated. So for 10 years, you have vascular disease before you even know you're diabetic. Unfortunately, as cardiologists, that's what we sometimes deal with is people tell us that they have diabetes for the first time. But when you do an angiogram, you clearly know that this has been probably for the last 5 to 10 years. So when you look at it, you can see that the low GFR and albuminuria are independently increase the risk of, cardiovascular death. Chronic kidney disease and diabetes precipitate peripheral arterial disease below the knee. PAD is very common in Asia, in South India, but it's probably not being diagnosed that much. There's a lot more people, unfortunately, who smoke now. When you add smoking and diabetes together, there is definitely peripheral arterial disease. So if you look for peripheral arterial disease, you're going to find it. Vascular calcification is common in chronic kidney disease and increases cardiovascular risk. The pro-inflammatory state, which further increases the cardiovascular risk from insulin resistance. development of heart failure, progressive kidney disease. One leads to another from neurohormonal activation, and things tend to get sort of a vicious cycle, one leading to another, and ultimately people die from the complications of diabetes, but not from diabetes alone. And obviously anemia goes forward with chronic kidney disease. So when you look at our scientific understanding, you can see that the mechanism of cardiovascular development in chronic kidney and metabolic syndrome, there are many ways by which the relationship between the heart and the kidney is bidirectional, and us addressing diabetes is just one of the many factors in terms of how we can help our patients. So this is just a very clear diagram which shows, one, there's an individual predisposition. All of us know that there are certain people, unfortunately, diabetes runs in families, and the people's, when your dad has diabetes, when your mom has diabetes, your brother has diabetes, the odds are, even though you're an athlete, you probably will develop diabetes because it runs in your family. So being very aggressive in terms of risk factor management would be very important. So there's a genetic predisposition. There's a clear behaviors that are involved when you look at CKM syndrome. I mentioned to you tobacco abuse. There's a high incidence of dietary intake of carbohydrates because of our rice eating. And then sleep is another huge issue that's happening now in India because of the high incidence of stress, the way our technology is taken over. People use WhatsApp at every time. It doesn't matter what time in the night you are, there's a WhatsApp message. People get into it. So the idea is sleep becomes a bigger lifestyle risk factor than anything. Finally, there's relationship issues which tend to creep up more and more, family, friends, peers. And then when you look at the larger issue with the community, schools, workplace, our neighborhood, how all of that impacts us. And finally, in terms of where India is today as a developing or developed country, and where healthcare is, where resources are, all of these things at some way or form will affect how we as physicians help to manage this syndrome of, cardio, kidney, metabolic syndrome, and diabetes. So what are the things that we can do? We should try and screen very early on in life. The screening should also try to figure out the subclinical diagnosis of diabetes. And as time goes by, there's a lot of emphasis on social determinants of health, which is very, very commonly done in India. Where we live, where we go to school, where we go to the temple, where we eat, all of that has a big influence on how we live our life. And that is more and more clearly seen now in every part of the world. And it's very, very common in America too. So sitting in the center of the country in greater Cincinnati and northern Kentucky, vascular disease in this part of the world is extremely common, just like in South India or South Asia for that matter. So addressing this at a population level becomes very important for that. Quickly going through the steps. So if you look at the steps, stage 0, stage 1 would be somebody with no disease and somebody who's just having abdominal obesity and may have mildly elevated glucose numbers. And stage 2 would be your metabolic risk factors or your progression to the syndrome. And stage 3 would be subclinical cardiovascular disease. And finally, stage 4, we don't want to go there, but that's kidney failure and all the problems that we deal with in the ultimate subset. Looking at where India is today, trying to look at 0 and 1 would be very tough, but we should make an impact and try to see how at a community level we can help. I want to give a shout out to, Balamurugan, my classmate and friend, for doing this symposium and trying to educate as many people as possible. I want him to continue the work that he's doing and take it out more to Coimbatore and also in the communities that, supply, that are growing more and more. And it's very, very important. And stage 2 and stage 3 would be where most people in India diagnose disease. And stage 4, unfortunately, is something that happens. So I'm not going to spend much time in stage 0 and stage 1, but stage 0 and stage 1 is very important as we go and try to educate our kids in schools and try to educate, our family members, our relatives, everybody that we can impact on in trying to prevent this syndrome. So stage 2, I just want to spend some time on stage 2 because this actually is the crux of how we manage cardiovascular diseases. Hypertension is not, I always say it's a lot easier to do an angioplasty and a stent than treat somebody with hypertension. Treating hypertension is more, an art rather than science, trying to treat the patient more than trying to treat the disease. So our goal should be to treat to 120 by 80, hopefully less than 130 by 80. The idea should be that we should be very aggressive in terms of treating our patient with hypertension, especially if they have comorbidities such as chronic kidney disease. We briefly spoke about hypertriglyceridemia. Hypertriglyceridemia is a very, very important factor which comes on very early on in diabetes. Trying to treat aggressively the hypertriglyceridemia, either with what I meant, the fish oils, or with fenofibrate, would be something that's very important. Finally, you have lifestyle changes, which is the metabolic syndrome component of it, and really addressing other metabolic factors. I know we use statins, but I can't emphasize the most important thing that, I can tell you a personal story, meaning my dad developed heart disease when he was in his 40s. I've literally been on statins for the last 25 plus years because I know cardiovascular diseases runs in my family. So this is something that we need to really address in India in a big way, because for some reason, Dr. Google and Dr. WhatsApp give us a lot of more information about the use of statins. But, statins reduce cardiovascular death. Statins prevent heart attacks. There's no doubt about it. And it's beyond LDL control. That's the thing. Most of us in medicine and in cardiology already know this. Reducing your cholesterol or reducing your LDL is just one aspect of it. There is an endothelial factor stabilization that reduces your risk of having cardiovascular events, that is stroke and heart attack, that happens with using statins, which is very, very important. Zadia is the other drug, which is ezetimibe. So when you use something in combination with statins plus ezetimibe, you get a good reduction in LDL. The SGLT2 agents, these are now catching on in a big way. They reduce your risk of heart failure, cardiovascular death, MI, revascularization, all of which are reduced. Early use of metformin, low-dose metformin, starting to treat a lot of my patients with very early stage diabetes who have cardiovascular disease or blood sugars between 100 and 120. I start them on low-dose metformin, trying to prevent manifest diabetes so that you could be very aggressive from the vascular front in terms of treating them. Chronic kidney disease, ACE inhibitors and ARBs are something that all diabetics should start, just like how we start them on low-dose statins, and low-dose ACE ARB is something that's very, very important. Finally, when you look at stage 3, that's the subclinical ASCVD, which means, it quantifies the risk of, your 10-year risk, so on and so forth. But really, the most important thing is to address and be very careful. You already have a diabetic patient with you. You got to assume that they have cardiovascular disease and treat them as such. And when you look at stage 4, you can clearly see that, I can spend a whole talk just on stage 4, which is a big section of what I'm sure you'll be hearing from multiple speakers tomorrow in your conference. But just to address some of it is aspirin. There's a lot of discussion about aspirin and cardiovascular disease now. A lot of us are moving away from primary prevention with aspirin. And I know in India, a lot of people use clopidogrel rather than aspirin. So the idea is to say, can you replace aspirin with clopidogrel? I know there are early studies that are happening with that. Aspirin, unfortunately, causes a lot more bleeding events than we can manage. The other word to address is obesity and the whole management of obesity with these newer agents, which are GLP agents. I think in India too, you can get now Ozempic and Mounjaro and all the newer agents that is coming on to prevent obesity. Hypertriglyceridemia, hypertension. Once again, all this is a continuum of how we manage patients with diabetes and cardiovascular disease. So when you look at globally how we manage this, I'm thinking this is my last slide, trying to explain that you need to work with others. It should be an interdisciplinary work. Work with your family doctors, work with your diabetologists, work with other cardiologists, work with the community health worker, work with the social workers, work with your diabetes clinical coordinators. All of them working together is very important. Addressing weight loss before it really affects people. Using cardioprotective anti-hyperglycemics before diabetes starts. Using cardioprotective agents once diabetes is manifested. Use of statin plus non-statin agents to reduce the risk of the morbidity and mortality. And finally, managing cardiovascular disease in patients with diabetes. I want to just spend I know this has been a global talk on how we manage diabetes. Just one or two words about interventional cardiology and diabetes. Most of us know that multivessel disease is very common in diabetes. We prefer to send patients with diabetes more for bypass surgery than for percutaneous interventions. Unless a patient has single vessel disease or two vessel disease, trying to send them for early bypass surgery rather than percutaneous intervention is something that's recommended by all the societies. Other than that, I'm going to stop here and take any questions. And I want to thank Balamurugan and his team for hosting this event. It's a great honor and a privilege for me to be here. But thanks everybody for listening, and I'm here for any questions or comments you have. Thank you.
Thank you, sir, for an excellent presentation, taking us through the problem of cardiovascular disease and relation with kidney, etc. I think 2 points which I would also like to stress is the lifestyle management should start very early. We should actually involve the pediatricians also to make them understand that maintaining an ideal body weight in child itself is important, because most of the people come and ask you, when should I start my lifestyle modification? As early as possible should be the answer, because childhood obesity is one of the factors which leads to adult obesity and later life problems like abnormal lipids, etc.
Couldn't agree more. Couldn't agree more. That's the most important thing. There are more high school kids who probably have diabetes now that we don't know about if we carefully start screening them. Yes, thank you. Please go ahead.
And the other thing which I think is important is weight reduction, which should be done, because many of us who have impaired glucose tolerance can actually bring down our hemoglobin A1C if we reduce weight by regular exercise, which is neglected most of the time. We also don't stress upon, and many of us doctors ourselves are overweight. So I think that is one good way, because we know that the minute you have an impaired glucose tolerance, your vascular disease has started. And
A couple of questions.
And there are some other questions here. So
Yes.
can we use aspirin for primary prevention in a diabetic patient? For which patient can we use it?
Second.
Well,
Can we use?
Yes, please
Can
continue.
we use CAC in general OPD for coronary screen?
CAC is
Go again. I didn't get that question. Can we use?
Calcium scoring.
Oh, calcium scoring. Okay. Next.
For general. Those are the two questions which have come.
Okay. So I'm going to answer the first question about aspirin and primary prevention. And I'll answer it in two ways. If you asked me this question 5 years ago, my answer would have been aspirin is absolutely indicated in primary prevention in cardiovascular disease. Today, I would say aspirin is indicated in documented coronary disease, in patients with documented cardiovascular disease. But as a primary prevention, I'm not convinced I would use aspirin anymore. Now, do I have a wealth of data to say this? Probably not, but that's where, as the AHA and as where we are going in North America, that's where we are going towards. Now, I will give you a word of caution. In patients with diabetes, unfortunately, diabetes, there's vascular disease, like just we spoke, before we can even find out that's vascular disease. So I want to be cautious about whether we can use baby aspirin or not. But given the risk of GI bleeding and given the risk of aspirin toxicity, I'm scared to say, can we use clopidogrel instead? I don't know. The data is not robust, but I know in India it's used a lot. To answer the second question, calcium scoring as a part of screening is absolutely important and can be done. But the only thing I would say is, in a country like India, I'm not convinced that, I would rather say if you have a diabetes, you already know they have cardiovascular disease. You got to assume that they already have coronary disease, because our incidence, the mean age of a heart attack in South India is in the 40s. So cardiovascular disease is extremely rampant. So for me to do a calcium score, I would rather do a stress test. I would rather get an echocardiogram and assess their LV function rather than investing in a calcium scoring. At least this, I don't practice in India anymore. I come for various events. So I want you guys to tell me how you would manage there in India rather than here. But this would be my opinion. Do we do that in North America? Do we have a big calcium screening program? Actually, in my center, every patient who gets a CT scan for lung cancer, we actually look at calcium scoring, and we screen all the patients with high risk, high calcium scores in the CT scan for lung cancer screening. We actually now look for cardiovascular disease. So that's different than in India. So please go ahead.
One point which I think is very relevant is treadmill test or an imaging modality with a nuclear cardiologist will be very useful in a diabetic, because they are going to be, many of them may be asymptomatic, and silent ischemia is something which we should pick up so that we can prevent an acute event.
I would agree.
The other thing I think the diabetologist should understand is the statin dose which we prescribe need not be reduced based on your LDL score, because basically it is not, as you really, actually said, that it is not based on the cholesterol level. It is basically for the pleiotropic effects which we are using statin, the vascular stabilization of the plaque, etc., which will be one of the important factors which will prevent an acute event. I think those are 2 points which should be driven to the diabetologist colleague so that, we are on par and we agree on that particular point. So that treatment becomes much easier. Any other question which has come?
Yeah. We'll go on to the.
Okay. Thank you, Dr.
Thank you so much. Looks like Marilyn is on. So she's going to take over. But Bala, thank you so much. We'll meet up next time I come home, and take care. Thank you, everybody. Wonderful conference. Thanks for doing this. So thank you.
Yeah. Thank you. Yeah. Welcome, Dr. Marilyn Tan and Professor Venkatraman sir. As I said, he's one of the senior, well-knowledgeable physician and diabetologists in the country. And my teacher will introduce Marilyn Tan and Marilyn Tan.
Thank you, Bala. Thank you so much for making me part of this wonderful program, and nice listening to a lot of faculty across the overseas, and then enabling us to have much more clarity in the subjects. Cardiovascular outcome, I think all of you will agree, is one of the hardcore endpoints that diabetes unfavorably impacts. So the key learnings in the last few decades have been, we have been able to appreciate from the epidemiological data of the cardiovascular disease across the world, various manifestations of cardiovascular disease, and also some of the broad learnings which I thought would be relevant, something as a prelude to Marilyn's looking forward to a discussion on this interesting subject from her, will be diabetic subjects need to be treated to a target, and this target needs to be as close to normal as possible in the early part of the disease, and multifactorial intervention is helpful. So a lot of key messages have emerged from very landmark trials based on strategy-based trials and also molecular-based trials. So maybe in the next 25 minutes, as I understand, Bala, it's almost 8:45. I'm sure Marilyn Tan will be comfortable for the next 25 minutes of presentation, and then we'll have another 5 minutes of discussion. Is it okay, Bala and Marilyn?
Yes, sir. Yes, sir.
Okay. Yeah. So to have the discussion on the diabetes and CV outcome trials bench to bedside, as I told you, a lot of strategy-based and molecular-based trials have been there, which have really enriched our knowledge and which have enabled the various guidelines to incorporate them in the various professional bodies to incorporate in the guidelines, so that it's a meaningful message to the clinicians to position and patronize the various molecules. To do this job, interesting job of enormous relevance in the contemporary diabetology and endocrine practice, we have Marilyn Tan, who is the clinical chief endocrine clinic and clinical associate professor of medicine, division of endocrinology, gerontology, and metabolism, Stanford University School of Medicine, California. As I run through your CV, Marilyn, I'm thoroughly impressed because the various aspects of Dr. Marilyn, composed of the clinical care, teaching experience, oral presentations, and the publications, each of them has got about 20 or 25 components. So I think it's really thoughtful of you, Bala, to have invited a very, very versatile person. So we look forward to listening to Dr. Marilyn. And before I hand over to Marilyn, in fact, a recent, I think, interest I've been in the case of in the areas of artificial intelligence, and the presentations are anywhere from pheochrome to your acromegaly, cardiomyopathy, Burkitt's lymphoma. I mean, huge knowledge of medicine and exposure that she has had. I think with this background, let me welcome Dr. Marilyn Tan to talk to us in the next 25 minutes about the diabetes and CV outcome trials, bench to bedside. Marilyn.
Thank you. Thank you all for the kind words and for the invitation, and thank you for joining me this evening. So as Dr. Suresh talked about, really, diabetes these days doesn't tend to kill people. It's the complications of diabetes. And so there is a large focus on cardiovascular disease, particularly in our South Asian patients. And today we will be reviewing the cardiovascular outcome trials that have come out in the last couple of years. In terms of disclosures, I have received consulting fees from Novo Nordisk and previously received research funding from GlaxoSmithKline. The outline for today will first review background on diabetes and cardiovascular disease, which Dr. Suresh already talked a little bit about, and then focus on the newer classes of diabetes medications, and then go over some updates on the cardiovascular outcome trials. So historically, we had a lot of studies examining glucose control and complications. We know that tighter glucose control is associated with a legacy effect with a reduced risk of complications later on. This was demonstrated very well in the DCCT and EDIC and UKPDS studies, but this is primarily showing a benefit for microvascular disease. So kidney disease, eye disease, neuropathy. Really, there was less evidence for macrovascular disease in all of these. And if we look here, we can see that in terms of cardiovascular mortality, really, we don't do a great job of reducing it with just glucose control. And even in fact, in one of the studies, it showed that excessively tight glucose control was associated with higher cardiovascular mortality. And then for some background on where all of these cardiovascular outcome trials came from, the earlier studies, as I noted, including the ACCORD trial, showed that hypoglycemia may actually increase cardiovascular risk. There have also been multiple medication-specific cardiovascular concerns where certain medications for diabetes come out and we found that, in fact, they're associated with higher risk. So, for example, the increased risk of heart failure with TZDs or cardiovascular events with a PPAR agonist that's no longer on the market. And then also prior meta-analyses have showed increased risk of cardiovascular events with sulfonylureas, primarily due to hypoglycemia. Therefore, in Europe and in the US, the FDA and the European Medication Agency, the EMA, require post-marketing cardiovascular outcome studies that include high-risk cardiovascular individuals to prove cardiovascular safety of these trials. And really increasingly, there's more of a focus on individualized A1C goals and really taking an individualized approach. So in the past, we said everybody should aim for an A1C of 6.5 or 7, but really we should be taking into account comorbidities. What is the life expectancy? What are the other cofactors? And also addressing other cardiovascular risk factors like blood pressure and lipids. And so, as we all know, insulin has been around for a very long time, but really that's the only tool that we had for a very long time. And then metformin and sulfonylureas came along, but really in the last 20 years or so, we've had a whole host of new medications, and that's where we'll spend our time focusing our talk today. In the end, though, as mentioned earlier by many of our experts, lifestyle changes really do remain the backbone of any therapy. And so no medication will do its job if there are not lifestyle changes involved first. And really, again, taking an individualized approach to therapy and choosing your agent based on the patient's comorbidities. So we'll skip over things like metformin and insulin and really focus on the newer classes of diabetes medications. Now, we cannot talk about the new classes of medications without first touching on incretins. Incretins are intestinal hormones that are released in response to meals that help to regulate insulin in a glucose-dependent manner. And it's thought that the incretin effect is diminished in type 2 diabetes. The two main incretins that we'll hear about are GLP-1 and GIP, both of which come from the intestines. And they're broken down by an enzyme called DPP-4. So first, the DPP-4 inhibitors. These have been around for about 20 years. They are oral medications, and they reduce the breakdown of endogenous GLP-1 so that your own body's GLP-1 lasts longer. They suppress glucagon production and enhance insulin production, and they're weight neutral. Then there's low risk of hypoglycemia when used alone, and the A1C reduction is anywhere from 0.5 to 0.9%, so fairly mild. These were the 4 major cardiovascular outcome trials in the United States for these drugs. I know that the drugs available in India are slightly different, but notably, saxagliptin and alogliptin were both shown to have a slight increased risk of hospitalization for heart failure, whereas sitagliptin and linagliptin were not. All of these studies are slightly different in terms of inclusion criteria, whether it be somebody with established cardiovascular disease or high risk, or recent MI, and all of them have different durations of outcomes, and also slightly different primary outcomes looking at either 3-point or 4-point MACE. But again, the takeaways are that 2 of them, at least of the US ones, were shown to have a slight but increased risk of cardiovascular risk for hospitalization for heart failure. Now, DPP-4 inhibitors are not used as much these days because there's so much more excitement about GLP-1 agonists. So as Dr. Suresh mentioned, it's essentially become a cornerstone in management of diabetes and cardiovascular disease. So GLP-1 agonists can come either as subcutaneous injections or as oral pills, and they raise GLP-1 levels to 5 to 10 times natural levels. We mentioned earlier that GLP-1 levels seem to be diminished in type 2 diabetes. And so these are much more potent at lowering A1C up to 2%. They have GLP-1 receptors in the heart, so there's a cardioprotective effect. The GLP-1 receptors reduce appetite in the brain, They reduce hepatic gluconeogenesis, they improve muscle uptake of glucose, and they slow stomach emptying. Therefore, all of these are approved for monotherapy for diabetes medications treatment, and also they are associated with weight loss, where in the US, many of them are FDA approved for weight loss alone, and increasingly they are being abused by celebrities and people with money for cosmetic weight loss as well. The main contraindications are a history of a rare thyroid cancer, medullary thyroid carcinoma, and a relative contraindication is pancreatitis or pancreatic disease, because there is a possible association with a higher risk of pancreatitis and with pancreatic cancer. These are the CVOT outcome trial. This is the summary of the CVOTs in the United States. So starting with liraglutide, exenatide, lixisenatide, really you can see here that there have been a lot of trials, and again, a large number of patients across all of the trials with varied durations, some looking at a 3-point MACE, some looking at a 4-point MACE. But the main takeaways are the exendin-based GLP-1 agonists, the exenatide and the lixisenatide, seemed not to have a cardiovascular benefit. They were safe, however, they didn't show any benefit, whereas the liraglutide, semaglutide, dulaglutide, and albiglutide studies for the injections all showed reduced cardiovascular risk, driven by stroke reduction and also non-fatal MIs. Interestingly, in terms of the background of these cardiovascular outcome trials, as I mentioned earlier, they were mandated by the European Medication Agency and the US FDA. None of these pharmaceutical companies wanted to do these studies. So I personally ran the Harmony Outcomes trial for albiglutide, and to enroll 10 patients, 5 of whom dropped out, it was $400,000 US at the time. So if you could only imagine, if you extrapolate that, to have a trial with 10,000 patients, how much this cost the drug companies. And again, these trials were designed to show safety. They were never intended to show any cardiovascular benefit. And so when we actually found cardiovascular risk reduction, this became extremely exciting for the drug companies, obviously, who are interested in making money, but also for us as clinicians and practitioners to actually have additional tools to help reduce cardiovascular risk. Now, the newest kid on the block is a GLP-1 and GIP agonist. And so GIP is the other incretin that you'll hear about, and the effects that it has on various parts of the body are slightly different, but we do know that it does also have glucose-lowering effects. And so the newest agent available is tirzepatide. This is a combined GLP-1 and GIP agonist. Comes in various doses, as all of these do, but the main thing I wanted to highlight here was that it was compared to semaglutide 1 milligram, which was previously essentially our most effective GLP-1 agonist. And even at the low dose of 5 milligrams, it had more effective A1C lowering. And then at the 15 milligram dose, it actually lowered the A1C in the study of up to 2.3%. So really quite dramatic for something that does not have a risk of hypoglycemia. In addition to this, they also looked at it for weight loss. And so it's been studied specifically for weight loss. And really, it's been a game changer where patients on the 15 milligram dose of tirzepatide over the course of many weeks lost up to 11 kilos. And so really, this has essentially become a bridge to bariatric surgery, which is increasingly common in the United States because most other approved weight loss medications either have long-term safety issues or they don't lead to very effective weight loss. And so this is really the first obesity pharmacotherapy to produce more than 20% weight loss, even though it was initially designed as a medicine for diabetes. Now, what about the cardiovascular outcome trial for tirzepatide? So far, there have been no safety concerns identified based on any of the patient data, but the cardiovascular outcome trial data is still pending. So we look forward to seeing what those effects are. And then finally, we'll finish up talking about the SGLT2 inhibitors. So these are oral medications that inhibit SGLT2, which is a sodium glucose cotransporter in the proximal tubule of the kidney. It reduces the A1C by anywhere from 0.5 to 0.7%, so a fairly mild medication. There's a slight weight loss associated, a slight reduction in the blood pressure, and no risk of hypoglycemia on its own. These were the 4 cardiovascular outcome trials that were notable. So looking at empagliflozin, canagliflozin, dapagliflozin, and erdagliflozin, and really you can see here that again, large patient trials and a very significant reduction in the risk of heart failure hospitalizations That's primarily what drove the cardiovascular risk reduction in these studies. And again, these studies encompassed high-risk patients and were done primarily in the United States. And so as we started to see these cardiovascular benefits, now we have a lot more interest from cardiologists and also from the nephrologists. Again, these were medications designed for diabetes. And I would say as a diabetologist, 0.5% A1C lowering at a cost of $700 a month, not that impressive for diabetes management. However, the renal and heart failure outcomes have been increasingly impressive. And therefore, for heart failure, many studies have actually looked at this medication in patients without diabetes. So the DAPA heart failure study that included non-diabetes patients, emperor reduced and emperor preserved using empagliflozin in patients with reduced ejection fraction and preserved ejection fraction, again, including non-diabetes patients, and then MPulse looking at hospitalized patients with heart failure, all very promising from a heart failure perspective. And then again, an unexpected byproduct of this medication is that it has additional benefits for the kidney, as we know that SGLT2 is primarily in the kidney. And so the Credence study for canagliflozin and the DAPA-CKD study for dapagliflozin and EMPA-kidney, these all included non-diabetes patients. And again, they showed a significant kidney benefit in terms of reduction of progression to chronic kidney disease. And earlier, Dr. Suresh talked about this cardiometabolic kidney diabetes trifecta. And really, so this gives us a tool that kind of addresses all three of these major risk factors. So the SGLT2 inhibitors, again, in terms of diabetes control, yes, it's an interesting new agent. However, it's not a game changer. But that said, really for heart failure, it has been a game changer, right? For the longest time, we had diuretics, ACE inhibitors, beta blockers, and actually at this point, SGLT2 inhibitors have now made it as step one in the American Heart Association and ACC guidelines for heart failure management. So this is for heart failure with reduced ejection fraction, and then for mildly reduced ejection fraction, and even for preserved ejection fraction, SGLT2 inhibitors are now first line, really especially for HFpEF or heart failure with preserved ejection fraction. They're limited in the tools. And the fact that SGLT2 inhibitors can improve outcomes is a game changer. That said, so far it sounds quite exciting. A pill that helps to reduce cardiovascular risk, lowers A1C, doesn't have a risk of hypoglycemia, is associated with improvements in kidney benefits. So what's the catch? Cost aside, there have been other concerns. So for example, when you put sugar through the urinary tract, especially in the setting of hyperglycemia, this does increase the risk of genitourinary infections and urinary tract infections. There is an association as well with diabetic ketoacidosis. So that's particularly a concern in patients with type 1 diabetes. There have also been concerns of a possible increased risk of amputations with canagliflozin, although that concern has kind of fizzled out. But again, just a reminder that as exciting as some of these medications can be, it's important to consider what contraindications there might be for the patient. So for example, if I have somebody who has bladder cancer and has had recurrent urinary tract infections, in my mind, an SGLT2 inhibitor is not appropriate for that person. However, in somebody with type 1 diabetes who has recurrent heart failure, a cardiologist may have a discussion with them and say, so if you get admitted once a year for diabetic ketoacidosis, is it better than being admitted 5 times a year for heart failure? So really, again, taking this risk-benefit approach with your patients and discussing what is the right medication for their individual situation. And then we'll finish up here with the recent studies of GLP-1 agonists and cardiovascular disease, as well as the updated studies of the SGLT2 inhibitors. And so these came out quite recently. The STEP-HFpEF study, this was looking at semaglutide in patients with heart failure with preserved ejection fraction, published this past year, looking at patients with without diabetes and with a BMI greater than 27 with heart failure with preserved ejection fraction. And it found that the use of semaglutide significantly improved heart failure-related symptoms and physical function and was associated with greater weight loss. They didn't actually power their study it long enough to look at heart failure outcomes in terms of hospitalizations or CV death, but it did improve the symptoms and physical function. STEP-HFpEF-DM was looking at essentially the same thing, but in diabetes patients. And again, it showed that in these patients, there was an improvement in the heart failure related symptoms, and there was greater weight loss as well. And then the SELECT trial, which was even more exciting, showed that semaglutide in these patients with cardiovascular disease and BMI greater than 27, but without diabetes, showed that the composite heart failure endpoint of death from cardiovascular causes, heart failure hospitalization, and urgent heart failure medical visits was slightly reduced, but the primary cardiovascular endpoint, most notably of death from cardiovascular causes, non-fatal MI and non-fatal stroke, was reduced by 20% for this primary endpoint in non-diabetes patients. So again, even though the semaglutide and other GLP-1 agonists were initially designed for diabetes, they've really become essentially cardiovascular and weight loss medications at this point. And we know that there are GLP-1 receptors in the heart, but we also know that weight is a large part of it. We don't think that this benefit actually is driven by glycemic control, right? We saw from the early studies, like the UK PDS trial, that actually improved glycemic control does not make a significant benefit in terms of cardiovascular risk reduction, and particularly not in the time frame that we see in these studies in a matter of 2-3 years. So we really think that this mechanism is independent of A1C lowering, and again, as demonstrated in this study, without diabetes. So the benefits are thought to be driven by the GLP-1 effects on heart, but also a significant amount driven by weight loss. And then to finish up, the SGLT2 inhibitor in cardiovascular outcome trials that are more updated at this point, dapagliflozin for heart failure with either mildly reduced or preserved ejection fraction. Again, a large study of thousands of patients looking at dapagliflozin, and it showed that it reduced the combined risk of worsening heart failure or cardiovascular death. DAPA-MI, looking at the impact on actually an acute MI, that showed that after 12 months, there actually was not an impact on cardiovascular death or hospitalization for heart failure in the setting of an acute MI. So again, kind of going back to our original cardiovascular outcome trials, showing that really the CV benefit for the SGLT2 inhibitors tends to be more driven by heart failure rather than for coronary artery disease. Similarly, this DICTATE study looking at dapagliflozin showed that it did improve some of the diuresis for the patients, but in the acute setting, it was not a complete game changer. And then the EMI study looking at empagliflozin with acute MIs, this was not designed to look at clinical outcomes, but looking at other factors, it did show that there was reduced BNP and then also improved LVEF and decreased cardiac volume. And then the IMPACT MI study that just came out in the New England Journal of Medicine this past month, again, showed no significant primary endpoint benefit from empagliflozin after an acute MI. So again, the SGLT2 inhibitors primarily for chronic kidney disease and heart failure, less so for acute MI. And then I'll finish up with a quick word on type 1 diabetes and cardiovascular disease, because the focus of all of these studies has been on type 2 diabetes primarily. But we know that patients with type 1 diabetes have a shorter life expectancy than the general population, primarily driven by cardiovascular disease. And the risk is even higher in women. So really, as with type 2 diabetes, it should be a multifaceted approach. We know that targeting just the glucose is not enough. We also need to look at lipid management, blood pressure control, anti-thrombotic therapy, as there was a discussion earlier with Dr. Suresh, management of obesity, management of heart failure, and chronic kidney disease. Certainly, I do a lot of GLP-1 agonist use off-label in type 1 diabetes, particularly for my patients who are overweight and obese. But SGLT2 inhibitor use remains a little more controversial because, again, looking at these studies, we know that there's a slight risk in diabetic ketoacidosis. But again, you have to have that risk-benefit discussion with your patient. If you have somebody who still has residual insulin production with type 1 diabetes and has never had DKA but has recurrent heart failure, and it's a reliable patient, then yes, an SGLT2 inhibitor may be warranted. But in somebody who's had recurrent DKA 5-6 times a year, maybe this is not the choice for them. And again, we think that it's primarily the benefit driven by diuresis, glucose excretion, and natriuresis, and then other potential mechanisms that still remain to be fully understood. In summary, the goal is to take an individualized approach for your diabetes patients, not only in terms of looking at the A1C goals, blood pressure goals, lipid goals, but really also to look at what agents are more appropriate. So does your patient primarily have heart failure? If so, an SGLT2 inhibitor. does your patient have primarily obesity? If so, then a GLP-1 agonist. And again, lifestyle and diet changes are the backbone to any therapy. And, it benefits not only just the patient, but also the entire family. And as Dr. Suresh said, so much of this is driven by family history and genetics. And so really you have an opportunity to improve the health of the entire family when you're focused on lifestyle and diet. And then, at least in the US, we really do need to consider the cost of these medications, because as exciting as they are, many of our patients cannot afford $1,000 a month US out of pocket, because sometimes the insurance does not cover. And so, excitingly, we are seeing more and more diabetes medicines going for non-diabetes indications, and that's where it's heading. And more remains to be seen. A lot of trials are still in process and not yet published, so we'll get more data as time.
So thank you so much, Marilyn. It was, as expected, a wonderful journey of the literature, which is, I think there is a transformation with respect to the therapeutic scenario of anti-diabetic drugs. So from a situation wherein an anti-diabetic drug has to prove its cardiovascular safety, now we are in an era wherein two classes of molecules have made a consistent and a favorable impact on the outcome of the cardiovascular disease manifestations and the renal disease. I think we are fortunate enough to practice diabetes at this juncture. That's what I tell my students and colleagues. And third thing is, I think you did nicely mention about the various trials on the GLP receptor agonist. Now I think we are in the part of realization that, yes, obesity has to be addressed not necessarily as a risk factor like hypertension, dyslipidemia, but probably an upstream approach right from the time, maybe in the pre-diabetic stage, in the metabolic syndrome, as has been alluded to by Dr. Suresh in the previous presentation. I think we have. So we have the knowledge that these aspects have to be targeted, and we have the science behind that, and some robust data and some soft data in the literature. And over and above that, we have the molecules to address this. I think how you place these molecules based upon the evidences and the patient in front of you. And Marlene, I would like to point out that we in India are fortunate to have oral sema being marketed in our country as well. Of course, the Pioneer 6 was non-inferior. We are looking forward to SOL data probably in a month or two. So I think just to end the brief summary of Marilyn's wonderful presentation, I think the journey of the understanding the cardiovascular disease and diabetes, its ramifications, and then the various molecules which have been consistently proven to be of benefit, which are available to the clinicians and which have been captured by the various bodies throughout the world in the form of guidelines. It is up to the clinicians to take the lead. I'm sure there'll be comments or questions. I'm sure Marilyn will be available with us for the next 5 minutes before we wind up. Some comments or questions in relation to from bench to bedside about the various trials and the molecules that are available to us to mitigate the manifestations of this, I would say, disease with a malignant potential, that is diabetes.
Elisa, do you want to say anything?
No, basically one thing which I appreciate is we have now molecules which does not really concentrate on insulin secretion, insulin sensitization, etc. Like GLP-1 agonist. And as a cardiologist, we have taken over the SGLT2 inhibitors from most of the diabetologists, because even people with high risk factors with diabetes, I think cardiovascular risk, we start using the SGLT2 inhibitor. And we are very happy with that drug. And we are also moving away from non-inferiority trials to, say, superiority trials, where this drug is superior and gives you a better result. So those are the changes which we as non-diabetologists feel is some progress in diabetology.
Professor Vaidyanathan, a comment in a lighter vein. I think you said you have snatched away the SGLT2. Shall we use the word, you're sharing the therapeutic space with the diabetologists with respect to some of these molecules?
Most of the cardiologists.
Suresh and Marilyn will appreciate this nomenclature. We will not allow it to be snatched. But one thing, yeah, you did tell in a nicer vein, because the DAPA-HF, DAPA-CKD, and the empagliflozin studies have shown that even the non-diabetic population, the endpoints have been so nicely addressed. And there are some signals to say that you can even prevent or postpone the advent of diabetes when you position these molecules for the various indications in the pre-diabetic.
The question is, imagine a new drug which has come in, which gives you a much better survival rate in those with heart failure, especially heart failure hospitalizations have come down remarkably with this drug, even in a non-diabetic, which was a revelation for most of the cardiologists. Hence, we have rather using it. And it has come as one of the pillars of, this is a guideline-directed therapy at present. So if you send somebody with a without a dapagliflozin, you should have some explanation for not putting that drug on. And your prescription is considered to be substandard if you don't put them on that drug. So my postgraduates will never send them if they can push a dapagliflozin, they will put a dapagliflozin.
So Dr. Marilyn, yeah, that's a nice comment and wisdom of, sharing of knowledge by Professor Vaidyanathan. So, Marilyn, there are a couple of questions. Can we use metformin and DAPA-COM to start with? I think the questioner wants you in the Indian context straight away. That is, when a patient walks to your clinic, maybe a recently diagnosed diabetes, drug-naive one, do you recommend a combination of DAPA and metformin? That's the first question. And the second is, of course, you did project about the meta-analysis in the diabetes care, about the unfavorable signals emanating from the sulfonylurea on board. So, of course, with respect to the cost and capturing the HbA1c target, even in the Indian context, we have, delayed the introduction of sulfonylureas, but in our context, it will be almost virtually impossible to practice diabetology medicine without the participation of sulfonylureas. In this scenario of the Indian context, first is a combo of metformin and DAPA as a straight prescription to start with early in the course of the disease, and then the positioning of sulfonylureas. Your thoughts?
So historically, metformin was our first line medication. In many ways, it still is. Primarily because it is a low-cost medication. We have decades of experience with it. We know their safety. There is no risk of hypoglycemia, but certainly some patients do have contraindications. So if they have chronic kidney disease, certain types of chronic liver disease, some people have gastrointestinal intolerance. But I think metformin and dapagliflozin as a combination to start is an excellent choice. Cost is always a consideration, and the practical reality in practice.
Bala? Yeah. Can you mute, please? The technical team, can you mute the others? Can the non-speakers mute themselves or the...
Yeah, it has been muted.
Yeah, please.
Muted, yeah.
Yeah, please.
Yes, go ahead. Yeah.
Okay, so the practical reality in my practice is that SGLT2 inhibitors and GLP-1 agonists are extremely expensive. And the way that the US insurance works is, for example, when our patients pass retirement and they have Medicare, these medications are supposedly covered, but covered does not mean zero copay. And many patients on a fixed income still have to pay $500 a month. So that actually really limits our use of the newer therapies. Sulfonylureas are actually completely fine in my mind. They are inexpensive, they are effective. And notably, one thing you mentioned about Indian patients, I treat a lot of Indian patients, many of whom are actually normal weight, which again, I think the pathophysiology of type 2 diabetes in Indian and Asian, South Asian patients who are normal weight is different from the pathophysiology in patients who are BMI of 40 or 45. But as Dr. Suresh mentioned earlier, in terms of the diet, there is a lot of carbohydrates in the diet, and SGLT2 inhibitors are not very effective for that. So this is a situation where a sulfonylurea or a GLP-1 agonist would actually be more effective because they better target those post-meal glucoses. And I didn't have time to talk about this, but really a huge game changer for us has been the use of diabetes technology with the continuous glucose monitors. Because then rather than just looking at an A1C, which tells you an average over 3 months, you can actually see what do we need to target for this patient. Is it the fasting glucose or is it post-meal? And really, if it's driven primarily by post-meal glucoses, the SGLT2 inhibitor is not going to do that much, and the sulfonylurea is going to be more effective for something like that.
Dr.
Thank you so much,
Venkatraman,
Marlin.
sir.
I think the message is absolutely clear. Yes, in the Indian
Sir,
context, so much as central adiposity, so it's worthwhile starting a patient on a SGLT2 inhibitor and metformin. So I always view this combo as a twin positioning early in the part of the disease for the metabolic capture without side effects of hypoglycemia and possibly some weight gain, especially central adiposity. And with respect to sulfonylureas, I think your points are well taken. I'm sure the initial data, I think they've been skewed a lot with respect to glibenclamide being projected as the prototype of sulfonylurea, whereas modified release formulations of glycoside as well as glimepiride in low doses, I think, which we are finding it so comfortable to use. So in the context of in the Indian diabetology practice, certainly you're not positioning it right after metformin. You have a lot of other options which have a meaningful effect on both the glycemia as well as the other components of the diabetic disease and complications. But certainly down the line, these two molecules, that is the sustained release formulation of glycoside and glimepiride in small titrated dose, certainly enables you to have a glycemic capture for a considerable period of time. And your point is well taken. Yes, in the Indian context, so much of carbs, GLP receptor agonist, balancing the cost effectiveness is a viable option. And since it's available in the oral form as well, I think clinicians should consider the positive aspects of the modulation of the various aspects of the disease by this class of agents, which are available to the clinicians. I think these are the three important messages that Marilyn shared with us. Thank you so much. If there are no questions, Bala, is it time for us to wind up?
Yes, sir. Thank you very much, sir. Thank you very much,
Thank you.
Professor Venkatraman, sir, Dr. Vaidyanathan, sir, and Marilyn Tan, and Dr. Suresh. And we had a wonderful session on cardiology. Probably, as Suresh said, we'll try to take it to the community level and educate the people in the community, health workers, as well as we will start teaching the school and college students also on this. Probably, I think we'll have a project to work on like that, because we don't need to, it's not enough just to educate the practitioners, physicians, and cardiologists alone. We need to go to the community level, and the students, very very important, even in the schools. We will plan to start. Thank you for your suggestion, Suresh. We'll definitely take it up.
Yes, thank you, Bala. For Dr. Venkatraman, we used to say bench to bedside, right? It's no more bench to bedside. It's bench to bedside, bedside to community. So the next focus should be bedside to community, because there's no point in us doing research for 100 patients, 1,000 patients. It's 300 million people to 3 billion people. That's what we should address as time goes on. So thank you so much, everybody. Thanks, Marilyn. That was wonderful. Thank you.
Primary prevention of diabetes should be one program, like a cardiovascular prevention.
Yes.
Thank you very much. Thank you all.
Thank you, everyone.
Thank you, Marilyn,
Thank you.
Suresh, and Sir.
Thank you.
Thank you. Probably all the other colleagues who joined here. Looking forward to the physical meeting tomorrow. Thank you very much, sir. Thank you.
Thank you, Bala. Thanks for the opportunity to connect with so many people in overseas and as well as in India. Big hello to Professor Vaidyanathan. Thank you so much.
Thank you. Nice meeting you, sir.
Good night. Good night, all of
See
you.
you, sir.
Yeah.
Sai sir, can we go off live?